Because part of the power is saying, yes, we are proud to be women in medicine. We're proud to hire women in medicine. Like we want to promote women in medicine, and having that message be loud in public is really important. And we're already starting to lose.
Welcome to Be Empowered, the podcast. This is a podcast where we dive into the realities of healthcare and entrepreneurship. We offer our opinion, unfiltered, unapologetic, and always with a dose of empowerment. We're here to amplify voices, yours and ours, challenge the status quo, and explore what it truly means to thrive. So let's get into it. I'm Dr. Santoshi Bilakota.
And I'm Dr. Shala Mokbel.
And today we have a very special guest. We have Dr. Arghavan Salles. She's a minimally invasive and bariatric surgeon. She also has a PhD in education from Stanford University. Her research focuses on gender bias and sexual harassment. Thank you so much, Arghavan, for joining us today. Do you mind just starting off telling us a little bit about your journey in medicine and how it led you to where you are today?
So I don't know how back we want to go, but I think there's a key pivot that happened in my career 6 years ago. I did general surgery residency. I did my PhD in between my second and third years of residency. And then I went on to do my bariatric and minimally invasive fellowship. And then I had a standard kind of academic surgery job for 3 years. And in 2019, I left that job. It was a really difficult and terrible situation. And when I left that job, I looked at other academic surgery jobs and ultimately opted not to continue down that path for funny reasons because I really like research. So I knew when I left there, it wasn't that I was going to go pick some other super clinical pathway. But I just knew that those experiences that I had had were not ones I wanted to repeat. And so I wanted to try to find some other way to continue to, at that time, I did want to continue to practice medicine in some way and then also be able to still do my research. And some, happenstance there was that I left, in the summer of 2019. And then it wasn't too long later that the pandemic hit. And so opportunities really shrunk at that time. As we all know, there were lots of hiring freezes and other things going on. Elective surgeries were put on hold at many places for periods of time. So it turned out to be a difficult time to be trying to make a transition to something different. And, we don't need to go through the painstaking details, but in the end, I landed in the position I have now, which is working in a department of medicine, which is pretty unusual for a surgeon. I was hired in this role in 2021 as they were building out their what we called at the time diversity, equity, and inclusion team. Those terms are, I guess, kind of verboten at the moment, but that was what was being built out at the time. And I joined three other really stellar women physicians who had been chosen for different roles related to that as well. And the four of us have worked together for the last 4 years now on all sorts of different initiatives for our department. Along the way, I applied for and got my first R01, which is a major grant from the NIH, and that was to study or test an intervention on sexual harassment to try to reduce the incidence of sexual harassment in biomedical research. And I was kind of on this path of doing DEI work and continuing my own research, which is broader than just the sexual harassment piece. That's just the only funded part. Until earlier this year, just like many other people, my NIH funding was inappropriately, I would say, terminated, and there's not going to be a way to get that money back. And we were at year 3 of 5 of our grant, so I'm now once again having to figure out how to pivot into this moment where what we used to call DEI is being called illegal, even though there's nothing illegal about it, but it's being called illegal by a lot of people, including those at the top of our government. And so, there are many like me who know that work is really critical, and we've not come anywhere close to achieving the goals that are intended by that type of work. So we really cannot afford to turn our backs on it. And yet we have to be really creative about how we continue to create just workplaces. On my research side of things, I'm definitely scrambling. It's a really tough time to be someone who does federally funded research, but especially in the areas that I work. And so I'm just in the middle of that.
That's really, really interesting, actually, with your background now pivoting into gender bias and sexual harassment research. Do you feel that being a woman in medicine played a role in this, impacted your journey?
Oh, for sure. I mean, I had done engineering as an undergrad, and I was always a math science person. And I have to admit, I didn't really think about my gender as being too relevant. I mean, I was aware of all the stereotypes, obviously, and people say things, but I always did very well, so it didn't really matter to me. It didn't seem super relevant until I started my residency, and that was the first time. I think for women in medicine, really women in any profession, we all come to a realization at some point that we're not living in a meritocracy, and that point can be earlier for some people and later for other people. I'm probably kind of middle of the road, that it happened for me as early as residency, but not earlier than. And what I really picked up on as a junior resident was how even I was treated differently from men at my same rank, but certainly also seeing how the residents above me, both men and women, were being treated by everyone, by the faculty, by the nurses, by other ancillary staff. There was a certain amount of respect and status that was automatically afforded to the men that was not, for the women. And this might include, like one of the more subtle things maybe that I noticed early on was when I was an ICU resident, I would write orders, on the computer, and hope that they were going to be done. And when I'd be following up, 45 minutes later, an hour and later, whatever, to see like what was the result of that ABG, or was whatever test that I had ordered, and the test hadn't even been sent yet. And this is in the ICU, right, where things are supposed to happen pretty quickly. And I'd have to go now back to the nurse, go to the bedside nurse and ask like why this test hadn't been done, or were they planning to do it? And it was only then that I would find out that they just didn't do it because they didn't think it was indicated. They didn't feel they needed to contact me to ask me about that, or that they needed to do it even if they didn't think it was indicated. They just felt it was appropriate for them to not do the test and to wait for me to notice that they hadn't done it and then follow up with them. And that's not a thing that the men I worked with experienced. Similarly, again, in the ICU, I'd walk into the room when I was leading a team and say, here are all the, we talk to the nurse, of course, about what's happened, and, do our formal rounds and say, like, here's the plan for today. And then have those plans be ignored or questioned in ways that other people's plans were not. And of course, questioning, I just want to be clear, it is totally appropriate to question, like, why are we doing this? And it's part of the nurse's very important job to advocate for the patient. So I'm not suggesting they shouldn't do that, but that I was noticing that it was done in different ways, for women residents compared to men residents, and also for our faculty. I mean, I picked up on that too, and that our women faculty were treated differently than our men faculty. And so when I went to do my PhD, it really was because I was interested in curriculum design and assessment, which is another big area in medicine that's not great, right? Once you get past the first 2 years of med school, which are very, as we know, structured and regimented and have really clear testing strategies. Once you get into your last 2 years and then go on to your residency, it's just kind of haphazard. And then people write these evaluations that are not necessarily super educationally sound. And so that's what I was interested in. And then I learned about some social psychology theories that I had never heard of because I had never done social science before, that really got me interested. And one of them was this idea of stereotype threat, which is becoming more controversial now. So I don't want to get into that. But the basic gist of the idea is that when there are negative stereotypes about aspects of our identity, they can affect our performance. So some of like the classic studies were involving either Black and Hispanic students taking SAT or GRE type tests, and they found that those who were asked to mark off their race or ethnicity before the test performed worse. Or there was a study of Asian women who were randomized to either be asked their race or their gender before they took a math test, and those who were asked their gender performed worse, controlling for previous or adjusting for previous math achievement. And so it kind of threw off this idea that we measured anything super meaningful with these tests, or that these tests were reliable in any way. And these are tests that we were making high stakes decisions based on, off of, I should say, like who gets into whichever college and who gets into whichever medical school. I had not that long ago at that time taken the MCAT and understood the significance of those tests. So I started thinking about how the stereotype that men are better surgeons than women might be affecting the performance of women surgeons, or as we're training to become surgeons. So that's kind of where that work started, which is back like, more than 15 years ago.
I think that's so interesting and necessary. I mean, these are things that I don't think a lot of people, I mean, I think we talk about it in like hushed tones, right? But there's not a lot of public acknowledgement that these things happen. And I don't think I know any other physician who's engaging in this type of work. I mean, you probably do because you are in that circle, but I think you're the first person that I've seen openly speak out about this. And I think that's great. And it's unfortunate what the current state of our country is in terms of funding necessary research like this. But one thing I wanted to ask you was every time I maybe talk about my experience, because the meritocracy thing, that's also a very good point. I realized that pretty early on. And as I was an academic physician, I realized that medicine is not cut out for women. We just don't make room for women for many reasons, right? Pay disparity,
Hmm.
fertility, relationships.
Hmm.
The divorce rates are higher for female physicians, all of those things. Even though 50% of our incoming classes are women, only about, I think, 30% are currently practicing, which is, Shal and I did a few episodes on this. So every time I try to share some of my experiences, the feedback I get is, well, things are changing, like things are getting better. But I'm not sure because I feel like there hasn't been that much acknowledgement that these problems still exist. Have you seen any progress, you think, in this area, or do you still feel like there's a lot more work to do?
I mean, I think it's both. One of my mentors in surgery had told me when she was, so she's maybe not 20 years, maybe older than, I don't know her exact age, but she's, a different generation than me when she went through training that, when she was a surgery resident on rounds, the team would go into the men's bathroom knowing that she could not follow. And I don't think people are doing things like that anymore. So I think that's progress. Now, one thing that is true is it's harder to fight the more subtle and insidious ways of exclusion and discrimination and bias. And that's the majority of what we see now, right? It's not that someone's going to physically exclude you from a space, but that they're going to not have you in their mind when they're thinking about who should be the next whatever to lead whatever initiative or the next leadership role. Because most people, and it doesn't have to be nefarious, but most people think about when there's an opportunity to nominate someone, we think about the people in our own circle or the people we've met with most recently. And for most people, that's going to be the people who are like us. And that means that men will tend to nominate men. Women in male dominated professions will also tend to nominate men because we're still surrounded mostly by men. Um, and all of that will continue unless and until we make intentional choices otherwise. So I usually recommend for folks that they keep a list of people that they want to support and sponsor and that it be very intentional. So it takes time the first time you write it down. But then once you've done that, when other opportunities come, you're not left with like, who did I meet with in the last week who's on the top of my mind? And instead, you can be more strategic about who you think would benefit from those opportunities. I think, yes, there has definitely been progress. We have conversations now that we didn't even have even 10, 15 years ago. And there continues to be a need for much, much more in this space. And I'm very concerned about what's happening both culturally and with our laws and as of this very moment, for example, sexual harassment continues to be illegal, but there was one of the executive orders that came out earlier this year almost implied that that could change. Executive orders aren't laws, and who knows what will come of that, but that's really concerning. This idea that intentionally creating opportunities for different people is discriminatory is really corrosive. And it's going to make it really hard for people to continue to do the types of programs that we know we need to do. I mean, right now we're having this conversation in Women in Medicine Month. I don't know how much anybody's talking about the fact that it even is Women in Medicine Month. And it used to be a pretty major push every year, I would see, especially on social media, people posting about it and having their grand rounds or other events celebrating women in medicine. I'm really not seeing that as much this year. It doesn't mean it's not happening. Part of it could be that people are doing it, but they're doing it quietly. But even that is problematic, right? Because part of the power is saying, yes, we are proud to be women in medicine. We're proud to hire women in medicine. Like we want to promote women in medicine, and having that message be loud in public is really important. And we're already starting to lose that. Not to mention what's happening for our underrepresented colleagues. I mean, nobody is even talking about that anymore, it seems, because people are too afraid of being accused of discriminating against white people, which is absurd to have to even say, but that's what's coming from our government, that's the concern. And so, physicians as a whole are pretty risk averse, I would say. And academic organizations are also very risk averse. So even things, they talk about like obeying in advance. I do think there's a lot of that going on because people don't want to be targeted. And whether it's individuals or institutions, like nobody wants to be targeted and have their career ended when they're trying to make good faith efforts to improve the situation for everyone. And so I think we're going to see a real backsliding over the coming years. And I don't think it's going to be 3 years, by the way. I think it's going to be for the next generation. It's going to take a long time, if ever, to rebuild to where we were even a year ago.
Yeah, it's really frightening and concerning because the effects of what's happening now, it's not going to be just a few months. It's a lasting effect, unfortunately, culturally and institutionally. So I'm with you on that. I've seen also some transgressions, subtle transgressions from women leaders towards women or towards minorities. What role do you think the leaderships in these small institutions and organizations play, and what changes they can make, especially now that we don't have the DEI? What changes they should be making to make things better for everyone?
Yeah, I mean, I'm not a lawyer, so I will have that disclaimer, but there is actually no law that outlaws DEI at this moment. There are executive orders that talk about not doing quote unquote illegal DEI, and illegal DEI is defined as I don't have the exact wording in front of me, but basically programs that discriminate against individuals, and that is not the goal or intention of any DEI program. In fact, DEI programs are designed to provide opportunities to people who have not historically had them, but not to the exclusion of anyone else. There's also this extraordinarily inaccurate and harmful narrative that's been pushed for years now by certain individuals and movements that DEI is about hiring or promoting people who are not qualified, and that's never what it's been about. Now, I can't speak for how every single person in DEI at every single company has implemented their ideas. Who knows what's happening, but at every single place. But I can say that for those who are really practicing DEI in the way that it's intended, it's not to exclude anybody, and it's certainly not to give opportunities to people who don't deserve them. The idea is to identify people who do deserve them and who may otherwise have been overlooked. And I just want to make clear, like, you're talking about, for example, medicine. What hospital would want to promote someone or put someone in a position of caring for patients who wasn't qualified to do so? They'd be exposing themselves to tremendous liability, not to mention the actual harm for patients, which of course none of us would want. So it's really a nonsensical idea to begin with in any profession, but especially in healthcare, like the idea that people would risk people's lives for the sake of some demographic chart in their organization makes no sense whatsoever. It holds no water. But the idea that there are Black people and Indigenous people, for example, and disabled people who could be excellent clinicians or researchers and might not otherwise be selected because of biases and discrimination and all that's built into our systems. Now, that's important to address. And if we really want the best people, I mean, that's the entire premise of DEI is if we really want the best people, we have to look more broadly than how we have been looking before. And I don't I don't think that's harmful in any way. So I just want to make clear that when these executive orders have come out, they've talked about illegal DEI. They're not actually talking about, I think, what most of us were doing as DEI. And yet it has had an intended chilling effect so that a lot of people and organizations are making choices to not do any of this work anymore, or to do it quietly in such a way that it almost isn't really happening, or at least that's my concern. And especially when it's something that's not illegal in the first place, I would love to see people push back more and say, actually, this is, what we're doing is appropriate, and we appreciate, the feedback from the federal government about, certain things like making sure all events are open to everyone, for example. And we'll make sure to incorporate that in the future. But otherwise, like, we will continue to seek talent in all the places where we can find it. I wish more people were doing that, and that's just not what I'm seeing.
We're going to pause here for this week, but don't go too far. We'll be back for part 2 next week, and we'll tune into the rest of the conversation. Thank you.